Okay, quiescence is a major therapy challenge for cancer in general, but specifically for ovarian cancer. So quiescence is the induction of a subset of cells taking on a slow, non-dividing state. And that seems kind of paradoxical why that should be a problem. But all of our chemotherapies have been developed to kill fast-growing cells. Cisplatin, Taxol, they work by targeting cells that are growing very, very quickly. And that's why things like your hair falls out when we give chemotherapy, because hair grows relatively quickly. Chemotherapy kills fast-growing cells, so the hair falls out. And that's how chemo works, is because cancer cells are typically growing very quickly. But within the cancer, we know that not all cancer cells are created equal, and there are some cancer cells that are growing slowly. In fact, they may only divide once every week. And so rather than cells that are dividing once or twice a day, and they're going to see chemotherapy when we give it over a 24-hour window, those cells, if they don't divide during that 24-hour window, they're not going to die. And we think those cells are causing chemotherapy resistance and causing cancer to recur. If we can identify and target quiescence, it has two very important therapeutic implications. So first is, we know in ovarian cancer that 70% of patients, unfortunately, are going to have a relapse. We can treat them, their tumor looks completely gone. There's no evidence on a CAT scan or with their tumor markers, yet within about 18 months, 70% of patients are going to relapse. If we had a drug that could stop those quiescent cells, so what we think happens, chemotherapy kills the majority of the cells. There are a few of these quiescent cells left behind, and then over 18 months, they start to regrow. They make more of those fast-growing cells, and 18 months later, we have a cancer. If we could arrest those cells, if we could stop those cells from growing, if we could freeze them in time, and then instead of that patient's cancer coming back in 18 months, maybe it wouldn't come back, or maybe it would come back 6 years from now instead of 16 months from now. So that would be what we would call a maintenance therapy, a therapy that we could use to prevent those chemotherapy-resistant cells from growing. It wouldn't kill them, it would just keep them frozen in time, and a patient would go about their life. And what we found was there are about 5% of cells that weren't growing, they weren't dying either. We isolated those cells compared to the other 9,995, and we looked at them and found what was different. By doing that, we've been able to infer a therapeutic. And so we have actually now discovered, I can't call it a drug because I can't use it in patients yet, but a compound that we're hoping will become a drug that actually, when we treat ovarian cancer cells, very aggressive ovarian cancer cells from patients, when we treat with that drug, they completely stop growing. They completely arrest, and they go into what we call a quiescent state. And we can characterize that biologically, but essentially they stop growing. So the big picture is that we can use this compound. We could treat patients with chemotherapy. Residual chemotherapy resistant quiescent cells are left behind. We could target them to force them to not grow. And then while they're quiescent, we can add a second drug and actually kill them. And that would lead to tumor eradication or cure. And that's the big picture. That's the goal. Is I think we can use this approach to actually increase cure rates of patients, which is what I've been striving my whole life for. And so that's the big picture. That's the goal.